Good morning, everyone. Welcome. This is a huge crowd. It's great to have you all here. So many different constituencies are represented here, too. Really, across the community, from community activists to from People's Clinic to our partners at Seton with their clinic system to a whole bunch of nonprofits that are working throughout the city, to for-profits that also care about what it is we're doing. So wonderful to see you all. I think that the sort of confluence of people here, it's really appropriate to what it is that we're trying to do through population health and through the entire school. So we are still looking for an example of a community that was forward-thinking enough, committed enough, passionate enough to raise their own taxes to fund a medical school. We haven't found that yet. Only in Austin has that happened. And that, of course, connects us to the community in a way that no other school is connected to its community. And that invigorates us in a way that no other school is invigorated. And that then takes us to this whole process of population health. So most schools don't have a department of population health. For us, this is pivotal, central, core, not just to that department, but to all the activities of the school. And in thinking about creating a department, Bill Tierney, our chair, was quick to jump on the fact that, hey, the school is of the people, of the community. The department needs to be of the community. So we were just talking, has there ever been an example of a medical school department that actually had a retreat to get input from the community on how to create that department? We don't think that's ever happened before. That actually the strategic plan for a department in a school, a pivotal central department in a school, was actually developed by the community again that it was meant to serve. And so another first, and another really appropriate first for us. So I'm going to get out of the way quickly. One of the key architects, one of the reasons that we were able to have this community step forward, really instill that passion, build on that passion to create the med school, one of the reasons that happened was Kirk Watson. And as you all know, he's one of the key, before I called you a key architect of the school, maybe you're the land developer or producer, or I don't know. It's not quite the right metaphor, but the key guy where it would not have happened without you. So I'm pleased to introduce him, and then he will introduce Bill. So,
I've said it before, and I want to say it again. When the community embraced the vision of 10 goals in 10 years, thus creating what the dean has already talked about a little bit here, creating this special connection between our people and our medical school. One of the things that we all were kind of nervous in anticipation is what kind of leader would we get at the medical school? Would it be someone that really gets the connection between the people of this community and the medical school? And I can tell you, we really did get the right guy in Dean Clay Johnston. It's just very exciting. And I got to tell you, it's fun. Some of you have heard me say it before. I love being your state senator, in part because I get to be involved in some pretty cool things that who would have thought I'd get to be involved in them. And this is one of them. Getting to introduce the new chair of, as the dean has pointed out, a department that you don't see at other medical schools, a department of population health. I told him recently, we were in a deal, that I have used the word population and I've used the word health, but I'm not sure I'd ever used them together before I met him and got involved in some of the things at the medical school. And what's important about that is that this community does have an opportunity to engage in a way that we've never done before. And we have a very special guy that is the chair of this new department. And let me just tell you a little bit about him. Dr. William Tierney is, as you know, the inaugural chair of a department called Population Health. He's a professor of population health at the medical school. He's a general internist, and he's a medical informaticist. Did I say that right? Good, close enough, he says. How do you say it?
Some people say informatician, but it sounds like very.
Well, I couldn't say it that. Yeah. And I don't think I could say it that way anyway, so we'll go with how I did it. He came to us, he came to the Dell Medical School after serving as president and CEO of the Regenstrief Institute. And I know I said that right because I've got it written down. And I want to dispel the rumor right now that the only reason he came to Dell is it's easier to pronounce than Regenstrief. He's president and CEO of the Regenstrief Institute, which is the country's oldest research institution dedicated to improving health systems. The Regenstrief Institute is a 501c3 nonprofit organization that supports the research and service missions of the Indiana University School of Medicine, where Dr. Tierney was Associate Dean of Clinical Effectiveness Research, and he practiced general internal medicine at the Eskenazi, another hard one, health clinic in Indianapolis, where he was the Chief of Internal Medicine from 2009 to 2014. His research focuses on improving healthcare delivery, a key reason we as a community wanted to have a Dell Medical School. He focuses on improving healthcare delivery and the outcomes through developing and implementing electronic health record systems in hospitals and outpatient venues, and he's done that in Indiana and East Africa. His team of developers implemented Sub-Saharan Africa's first ambulatory electronic health record system in 2000. And listen to this. It has grown and evolved into the world's most widely used open source electronic health record system that's been implemented now in more than 40 countries and nationally across Africa. Dr. Tierney is a member of the Institute of Medicine and the Association of American Physicians, and is a fellow of the American College of Medical Informatics and master of the American College of Physicians. He's received the Lifetime Achievement Award from the nation's leading organizations in 3 disciplines: academic general internal medicine from the Society of General Internal Medicine, biomedical informatics from the American College of Medical Informatics, and translational science from the Society of Clinical and Translational Science. We have another rock star in our midst. Ladies and gentlemen, we live in a special time in Austin, Texas, in part because the special people voted to create a medical school in our midst. And as part of that, it is my distinct pleasure to introduce to you Dr. Bill Tierney, the inaugural chair of the Department of Population Health. Dr. Tierney.
The reason I'm here is the third line of the title, is that this is a unique opportunity that I jumped at when I had an opportunity late in my career to try to do something new and unique for both myself, but also for the people that we serve. The first thing is what is population health? I mean, as Senator Watson said, I spent most of my time working within health systems, both from a provider level, from a practitioner, up through being an administrator within those systems. And I'm very comfortable doing that. So for me, I was a primary care physician, so I took the provider's perspective. Population health was the health of the people for whom I was their primary care physician. It wasn't a huge number of people, but I cared a lot about them, and I did my best to serve them in their healthcare needs. So there's also the hospital system perspective. I was the chief of medicine for the hospital, so I cared a lot about the people coming in the door that my department was responsible for. And because I was in the leadership of the entire organization, if you took Brackenridge, added all the FQHCs, federally qualified health centers in town, doubled it all in size, that was what we had in Indianapolis. And I was the chief of medicine, which is about half of all of the 1.4 million encounters a year for there. So we knew our patient population was about 1/3 people that knocked on our doors every year. The health system gets even larger. So I was also part of a thing called Indiana University Health, which is an 18-hospital network across the state. And they had their perspective, or the people that are knocking on their door, and they care a lot about, and they try to do their best to care for those people. Then the health insurance company's perspective, or the perspective of, say, health maintenance organizations, et cetera, are their clients, the people who've elected either through their employers or personally to buy their product, and they care about the people that they're serving, okay? Then there's the Dell Medical School's perspective, which is different. So I stole this from their website. This is the vision and mission statement from the Dell Medical School. I'm not going to read the whole thing, but two things I thought that were helped us understand what we're thinking about when we talk about population health. It's that our vision is to be inclusive, open to everyone. It doesn't say open to every patient. It doesn't say open to everyone knocking on your door. It says open to everyone. And also the ecosystem is a complex of a community and its environment functioning as a system. So we're talking about the community. We're not talking about the healthcare system. We're talking about a health system, which both is within the healthcare environment and what I like to call the health caring environment, which is outside the walls of the health system. And for me, that was a stretch goal. I had not been involved in that aspect of health. I focused on the healthcare environment. For me, this was a way to grow and learn and develop in ways late in my career that I was not going to have an opportunity to do in Indiana. But part of the mission is directly related to what we're doing, which is improving health in our community as a model for the nation. So this is our charge. Was that this is a working thing. While I was writing this, we changed it again. I mean, this is something that's going to continue to evolve, and this department, this school, is going to continue to evolve as it realizes its mission. So this is our current definition of population health embedded within the department's mission statement, which is the mission of the Dell Medical School's Department of Population Health is to enhance the health and well-being of the residents of Austin, Travis County, and Central Texas, with emphasis on vulnerable persons and those suffering from health disparities. Now, why the latter? Aren't we being supported by all the taxpayers? So why are we focusing on those? We live in, if you look at Austin as a city, it's actually a pretty healthy city. But there's this called the tyranny of the average, below the average. If you want to make the population better, focus on the people who are actually suffering the most. And those are people in the bottom 20% of the health indicators that actually need help, and we'll raise the entire community by raising that portion of the community for whom there's a lot of bad outcomes and a lot of money being spent unwisely. The problem is that departments of population health essentially don't exist within schools of medicine. There are only 5 in the country, and they're all very different, all established for different reasons and in different places. Austin itself is unique, the medical school is unique, and the relationship between those two things are unique. We're starting from scratch. We decided that there's just no way that we can find a model and say this is what we're going to do. We have to actually start from stepping back and saying what should we be doing. So we had what Clay referred to. We had a population health summit. And this is something I asked him to do and fund before I even got here. And so I'm spending his money before I'm even here. But the point was that I wanted to crowdsource this. I wanted to make sure that we were meeting people's expectations, which means we have to help people set their expectations, and then so that in ways that we actually could meet them and they could be satisfied and actually work with us on those things. So I decided that we ought to do this together, both us and the community, both the community, what happens out within the people and government of Austin and Central Texas, but also within the local academic community. This included local community organizations. It can be the Austin and Travis County officials, Seton Central Health, Community Care, other Austin healthcare providers, foundations, and then on the academic side, Dell Medical School, UT Austin, other health-related schools in UT Austin, other people from other UT campuses, other Texas universities, and then a smattering of about a dozen national experts in various aspects of health and health delivery. And chairs of 3 of the 5 existing departments of health. It's the only time they'd ever gotten together. And actually, we're talking about developing an organization of departments of population health, because since we've established here, a couple of others, including Duke University, and I think I'm blocking on the other one, have formally said we're going to establish a department of population health. The idea is catching on. So we sat back and said, what do we want to hear about? What are the general categories we want to hear about? And so we kind of made this up, and then we floated out to the people who said they wanted to come, and came back and adjusted it a little bit and said we wanted to talk about community engagement, we wanted to talk about public health, we wanted to talk about occupational and environmental health, health data, and I'll talk about that a little later why that's important. Health services and community-based participatory research. We're an academic organization, and we discover and we innovate. and global health. And that might not make sense, but I'll make it make sense in a bit. So we broke into small groups along those 6 lines, and we charged them with these things. That define their focus and areas of emphasis. Okay, should this be a focus of the Department of Population Health? And if so, define it. Help us understand what it means. Suggest qualifications for a leader. Who should I be looking for to lead that person? And I'm hoping that some of the people I invited actually want to do that. And next, identify 2 or 3 initial activities they would like to result in early impact on population health. And the end result of this was what I'm going to present to you, which is a strategic plan for the department. But before I did that, I actually this morning went through my notes, and Lori Cook, if she's here, her notes from that meeting, and I pulled out some things that we heard that I wanted to make sure guided the things that we did. And so I'm going to just kind of read you some of the bullet points that I took from that meeting. Be thoughtful about your engagement. Generate trust through engaging people and being transparent. Listen to the community affected by health issues. Be humble. Start small, look for early impact. Have a vision that's mindful of the needs of the people we serve. Have balanced goals, making you better when you're sick and keeping you well. And get to know the community, especially the history and reasons for inequities. And most of the people coming from this medical school come from other medical schools, and since there wasn't one here, most of the people are from elsewhere. So getting to know Austin and the history of Austin is something that we must do if we're going to serve our mission. So we've got a department, and I'm going to tell you that right now where things stand with the foci of this. It's a working, living document. It's going to change. These things will evolve over time as the medical school evolve over time, but consider this kind of the start. This is what it looks like coming out of the gate. These things will change as we recruit leaders for these things, and they put their own imprint on what we're doing. I expect rapid evolution of this, and that'll be a very good thing, not a bad thing. So first and probably most key is that we're going to have and I don't know, we've struggled with labels. This is a section, is it a division, is it a program, and I don't care. We're going to have a thing that we call community engagement and public health. Now, obviously, community engagement is something that we want to do, and a lot of other medical schools are doing it, but they often do it to serve another need. So they have a community engagement program that helps their researchers find a place to do their research. For us, this is an end in and of itself. That we consider the service for the medical school to anchor ourselves in the community, to understand the community, to understand what their needs are, to understand ways that we might partner with them. Now, one of the key things, and this is something I've been really struggling with, and I need your help with it, and hopefully during the Q&A you can tell me some of these things, and that is that we don't know how to help. I mean, in Indiana, went back there, we have the largest medical school in the country. There's only one in the state. The state is 20% the size of this state, and we had 9 campuses in all over the state and a huge organization. We owned healthcare in the state. If we want to do something, we just did it, okay? We got a small medical school that's part of a big established university inside of a city that's got a lot of stuff going on. So my question to you all, and noodle on this while I'm talking, and please give me feedback now and later, is how can we help? How can we have impact on what you all are doing or on what you all see needs doing? But we can't do it alone. We can't even own it. But what we can do is have impact. And none of us actually knows how to do that. So I'm going to rely on you, both from the community and from academia, et cetera. Help us define those roles, both in macro kind of directions and micro individual things that we can do. There is a School of Public Health. So aren't we tromping on somebody else's turf here? And the answer is no. I see this as not a conflict of interest, but a confluence of interest. That we both care about the health of the public. We approach it in very different ways. I've worked with schools of public health many times in the past and helped develop the school that was just developed in Indiana, and I was involved in recruiting its dean, and then I left after doing that. So this is a place where our public health school UT Houston's regional campus has been active. So my question to them is, how can we help? We care about the public's health too, so how can we do this? But we have to do this because this is really part of the mission of population health, is health of the population. For us, the population is the people living in Central Texas, so we care about that public, both measuring, understanding, and implementing and doing. One of the first things that we're going to do out of the block is that even before I arrived, we were the recipients of a generous grant from the Michael and Susan Dell Foundation to launch a Center for Place-Based Initiatives. And place-based simply means solving local problems with local resources and local ideas. And so just this week and last week, we're interviewing candidates for the director of that institute. The notion is if people have an idea but they haven't implemented it, it's usually because they lack some kind of resource, either some funding, some experience, some some kind of help in either conceptualizing the idea or bringing it to fruition. So we're going to advertise for ideas from the community. We're going to help them develop proposals, and then we're going to have a community group sit and decide who gets the resources, and then implement these things over a period of hopefully a year or less, show what the effect of these interventions can be, what these ideas can do, and then look for who is affected by those and see if we can't bring in some kind of resources to take it to scale. But the notion is that all of these ideas are going to come from the community. They're going to involve resources from the academic environment to help power them, but they're going to come from the community. And this is going to start as early as this summer. So hopefully you'll be able to see finally, after all the time of ramping up the medical school, that we're on the ground and working with the community to help develop these ideas. So that's something that we're very excited about. But we also care about healthcare delivery. You know, the healthcare delivery system, I've had somebody else tell us that we've got the best care in the country and the best care in the world and the worst service. A friend of mine's son developed testicular cancer at the age of 15 and had to have 3 months and 14 separate visits before he got treated. My friend was the president and CEO of our physician practice plan. If it took him that long, think how long it would take each of you to get that kind of stuff done. And this is a life-threatening disease. So great care, he survived it, lousy service. So we can do better at this, and we can do it in a more cost-effective way. There's an estimate that a third to half of the dollars that we physicians and we, the healthcare system, spend on care is wasted. And not only wasted, but maybe harmful. There's an inverse correlation between the amount of money you spend on healthcare and how well people do. The more you spend, they do worse, actually. By ordering inappropriate care, by doing inappropriate things, you get all the side effects and no benefits. So we're going to be working with Rich Freeman, the Associate Dean for Clinical Affairs, and the other departments of medicine and peds, et cetera, to develop new value-based care models that look at what can we do to get the most care for the healthcare dollars, and see if we can establish new models of care. Where the country is going anywhere, we want to be able to lead that care, and this department is going to be part of that. So we're going to have a vice chair for clinical affairs that's going to be working with his or her counterpart and the other departments and with Rich to help develop this. Occupational health. I would bet that when we started talking that there wasn't going to be anybody saying occupational health. Because most of us think that is on-the-job injuries and workman's compensation and disability and stuff like that, which is all true. However, we've got Ed Bernanke here who's got some really good experience and ideas about helping employers. I mean, here's a place where things are tied together. An employer, if he can keep his people healthy, it's better for the company. And if they're paying for the health care, which I was the president and CEO of a small company, we were paying for our health care, and I cared a lot about what it was costing, then if we can work with them to develop programs for their employees and their families, and not just work-related, but primary care and comprehensive programs, it'll actually save them money and allow us to care for larger and larger populations. If you think about it, if you start getting a lot of employees and their family members, you're approaching population health. So a lot of very innovative things that Ed's going to be doing, and they're highly relevant to what we want to be doing in population health, and not just in big companies that are self-insured. But we've had some discussions about launching special clinics for musicians who are often uninsured, underemployed. They work in dangerous places where there's both violence and intoxicating substances consumed occasionally. I know you never go there, Kirk, but you know. And so that's just an idea that we should be doing something like that because it's iconic for this area of the state. It's iconic for the country, and it's something that we can and should be doing. So the top three are really, in academia we have this thing called the tripartite academic mission: service, teaching, and research. That each faculty member focuses on one of those things, but each department, each school has to be excellent in all three. The top is going to be predominantly service-oriented. However, we are going to have both the left brain side of what we do too. And starting off with informatics and data analytics, you can't make something better if you're not measuring it. You can't deliver good health care. You can't understand who in the community needs help if you don't know who they are, where they are, and what they need. So, and as much as you want to call Austin the Silicon Hills, you're in the dark ages when it comes to health information sharing. Nothing's happening here, which is actually a good thing, because we can build a state-of-the-art system that nobody else has. We had one in Indiana. So the one I left, we developed in 1987. Yes, I know some of you weren't alive then, but back in '87, we were linking hospital information systems together, and it now includes 110 of the 120 hospitals in the state, and it's the largest health information exchange in the country, and we can do better than that. That technology was rolled out 10, 20 years ago. It's not a technology problem. It's an issue of the health providers and the public health data gatherers being willing to share their data for the public good. And I can report, having had a couple of meetings with this, is that the healthcare providers, the big ones and little ones, the people who've done a little bit of information sharing around here already, and the community are behind this. So I don't think we're going to have the kind of mine and not yours approach to this. I think people understand that we're sharing care of the patients and we're sharing responsibility for the public's health. So I think you're going to see this being launching very soon. But also, the thing that people like me who develop information systems, the knock on us across the decades has been we care a whole lot about getting data in, but not about getting information out. And so in healthcare, we're drowning in data and starving for information. And so we're actually going to build those things together in one institute where they got to be talking to each other, so that the data analysts are telling the data gatherers the type of data they need and the format they need it in, so they can best help both healthcare providers and researchers and developers and innovators have the information they need to be able to strategically plan for what the community needs. Now, the R word sometimes scares people, but we can't, a lot of what we want to do, we don't know how to do. We just don't know how to do. The medical school, the entire healthcare enterprise in this country is changing and needs to change, and everything we're doing is new. And no one really knows what the return on the investment is going to be. We have to be out there helping figure that out, especially in the models that we're doing. And there are two kinds of research that are, we're not going to do basic science research where we're tearing apart DNA molecules and stuff like that, although we'd like to support that happening. But what we care about is what happens in the community and what happens in health systems. And those are actually two fairly distinct, not completely separate, but fairly distinct disciplines within the research community. So there's community-based participatory research, which is where researchers involve the community in understanding what the big, hairy problems are, and then involve the community in identifying those and solving them. At the same time, there are health system problems that require people who know about health systems and data and workflow and things like that, and different models of care and policy, and putting those things together into one research unit. And it may eventually split into two, depending how things go, but one research unit where they get to share resources, they get to have some economy of scale and things like that, and get to maybe grow a little more quickly with colleagues that might even cross those two kinds of research. So obviously we've got a teaching mission, and this medical school, you don't understand how innovative the approach to medical education here is, and baked into that is an understanding that when I went to medical school and when Clay went to medical school, we were taught the person sitting across from us or lying on the table in the emergency room or in the bed in the hospital, diagnose and treat. And I'm damn good at that. Okay, we're really good at diagnosing and treating, and that's what we get paid to do. We're not so good at keeping them from getting there in the first place. Is it better to spend a lifetime treating somebody for type 2 diabetes, or give them a free pass to the YMCA, which we know reduces the chance of a pre-diabetic getting diabetes by half? Why shouldn't we be engaged in those kind of things, and why shouldn't our students know that those are arrows in their quiver? So, and shouldn't we be instilling in them the notion that preventing something is better than treating something? And hopefully with the value-based care revolution that's happening, 3 days ago there was an article on the front page of the paper talking about value-based care and how people are pushing back because it's hard to measure and stuff like that. We'll figure those things out. We've got to go there. And we've got to have students that are educated with that in mind, not with what was in mind when I was educated. And I don't think any place is happening better than here, especially not just in isolation. In my old environment, when I was rounding on the inpatient service, we have medical students, and we actually had the pharmacy students rounding with us. At the same time, the nursing students were running on the same patients, and they weren't talking to us. And the social work students were running on the same patients and they weren't talking to the other. It's stupid because when they get out into practice, they're supposed to be talking to each other. So why can't we do that together? And the answer is because you've got all these different curricula, they're already completely filled, and it's very hard to change that. There's nothing to change here. You're creating something new. And so from day one, IPE, or interprofessional education, has been key, and we're going to be part of that. And there's certain constructs of population health, both from the nitty-gritty of sensitivity and specificity and screening and prevalence of disease and stuff like that, but also to social justice and focus on prevention, focus on community resources, et cetera. So that's going to be really key. And then finally, global health. Now, on the face of it, that doesn't make any sense, does it? If we're here to serve Austin and Central Texas, then why do we care about what's happening elsewhere? And by global health, I don't mean Sweden and Switzerland. Okay? And the answer is that global health in developing countries is population health. If you've got, when I spent a lot of time in East Africa, mostly Kenya, Tanzania, and Uganda, and they spend $8 to $10 a year per person on health. The government does. They're not buying ventilators and intensive care units. They're buying antenatal clinics and vaccines and digging wells that have uncontaminated water and stuff. It's all population health. And if you expose your trainees to that kind of environment, guess what? When they come back, they see our health system differently. You kind of instill in them a notion to see beyond the walls of your health system. And there are the practical things, So Tim Mercer is one of the directors of the program that I was in Kenya. And when people go there, I can't get an MRI on everybody to figure out what's going on. Guess what I have to do? I have to do a physical exam. And guess what? They've got diseases that we don't have much here anymore, like valvular heart disease and things like that. And guess what? It's become relevant that last time I was there, the first time I was there in the late 1990s, it was tropical diseases, malaria and TB and diarrheal illness and stuff like that. When I went back 5 years later, it was AIDS. The hospital filled with young people dying of AIDS. Now that we've launched AIDS treatment programs, I went back there now and rounded, and a third of the patients had strokes. 2 patients had a heart attack and 3 patients had cancer. What does that sound like? Sounds like Brackenridge. So they're in just that period of time I was involved, they've westernized their problems. So what's there is not irrelevant to here, and it's actually cheaper to study interventions there than here. And so we are going to be doing innovations, and we're going to repatriate the ones here that seem to work. So this is highly relevant to what we're going to be doing, and medical students want to participate in this, and I think we'll get a better class of medical students. This is key too, is that we have to make sure that everything we do in all these things resonates with the community. And how the heck would we know? We aren't typical of the community in Austin, especially East Austin. And so I've engaged a community organizer who's helping me put together a community strategy team that and just this week, as I was interviewing patients for applicants for the job of director of our Center for Place-Based Initiatives, members of that team were on the interview team. I want to vet leaders with them. I want to make sure that they're seeing who we're bringing in, input to me, who we hire, who we shouldn't hire. I want them not just to be reactive to the things that we do. I want them suggesting things that we ought to be doing. So we're going to be meeting with them on a regular basis, and they're also going to be helping provide insight to the entire medical school. So they're going to be really key to everything that we do, and that's why they're in the center of this. How are you going to know if we did, I'm trying to influence my boss here now. So how are we going to know if we're any good? Are we actually getting anywhere with this? And that's actually pretty hard because it's not going to be some big randomized controlled trial. It's going to be a lot of little initiatives. Fulfilling the mission, so we're going to ask people what they think. Imagine that. So the community strategy team is going to give us feedback on a regular basis about whether or not they think we're making progress. The community organizations we've surveyed, the Dell Medical School and its leaders, and the leaders of other schools at UT, healthcare and academic partner organizations, and then the city, county, and state governments. Are we doing any good? Can you see impact of what we're doing? The increasing number of things that we're doing. So what projects are we actually doing, and do they seem to be having impact when we do them? And moving the needle on important measures of health is determined by the community. So what does the community think should be a measure of success? I actually don't know the answer to this question. These are kind of mostly process measures. The outcomes are going to be important. Yes, there are going to be other things that affect them. You know, the number one killer in Austin, Travis County now isn't heart disease, it's cancer. Well, you'd like to think it's because we're a healthy city. I'm guessing it's because of the medicines we use to prevent heart disease these days. So how do we know we made any good? I'm going to ask the community to help us solve that problem. Establishing useful and used health data infrastructure for Central Texas. So if we actually are able to establish a way that healthcare providers can share information, that we can actually do planning for people's needs in the community because we've got the public health data and can merge those with the healthcare data, et cetera, then I think we've moved the needle. Extracting useful information from the data and acting on it. Don't just collect data for data's sake. If the thing's not being used, then we didn't create something that was useful. But show how the data are actually making it easier to meet the needs of the people in the community. Discover and implement useful community health system innovations. You know, do our research efforts yield something that anybody cares about? Integrating population health principles throughout the medical school residency curriculum. You know, work hard with the rest of the medical school to make sure that the orientation of the students goes beyond diagnosis and treatment. And cementing a partnership with a medical school in a developing Hispanic country as we develop our public health program, have a partnership that's mutually beneficial, but mostly focused on developing health-related infrastructure and capital capacity in the developing country and gaining from doing that. Becoming a model of other departments of population health. Again, they don't exist. Our summit is actually defining a new discipline. And so we're going to broadcast that and hopefully help other departments at least decide what they ought to be thinking about when developing a department. And then finally, being something that Austin and the Dell Medical School can be proud of. Now, I'd like this to become iconic. You know, medical school and our department become iconic for Austin and Central Texas. Perhaps not as iconic as bluebonnets, but iconic. This is my granddaughter. Okay, my grandparents got to show pictures of the kids. But I would like at the end for her to grow up in a healthy and safe city where the only barrier to her realizing her dreams is her abilities, et cetera. That there aren't other things that are getting in the way. And not just her, but everybody who is fortunate enough to live here. So, and I want to end with this. I came across this and I thought it was highly appropriate. It was written 300 years ago. It was a friar's blessing from the feast of St. Francis of Assisi. May you be blessed with a restless discomfort about easy answers, half-truths, and superficial relationships so that you may seek truth boldly and love deep within your heart. May you be blessed with holy anger at injustice, oppression, and exploitation of people so that you may tirelessly work for justice, freedom, and peace among all people. May you be blessed with the gift of tears to shed for those who suffer from pain, rejection, starvation, and the loss of all that they cherish, so that you may reach out your hand to comfort them and transform their pain into joy. And finally, may you be blessed with enough foolishness to believe that you really can make a difference in this world so that you are able to do what others claim cannot be done. The Dell Medical School is launching on an ambitious, inspiring, and likely impactful journey, and I want to thank Dean Johnston for allowing me to participate in it. Thank you. So we've got, probably 10 or 15 minutes at least. I'm going to answer questions only people want to ask them, so that's fine with me. So I'd love to hear where you all think we can make a difference. And a couple of people with microphones, Dr. Miller.
Yeah. Thank you, very inspiring. We really appreciate both you and Dean Johnson and your mission and bringing this wonderful medical school to our community. My question has to do with healthcare disparities. You may have heard me ask this question before, but I'd love to ask the question. How are we going to deal with healthcare disparities, especially in our community? African-American men still don't get catheterizations with the same insurance. Hispanic women have higher degrees of cervical cancer. How are we going to deal with those very tough issues while you're changing the model of healthcare in this community?
Well, you've asked probably the most important healthcare delivery question that, of our age. If anybody tells you they have the answer to that, they're lying to you, because this is a process and not an answer. So I think this is the type of thing where, first of all, you have to shed the absolute bright light of day on it. Make sure that everybody knows that African Americans have less pain medicine given when they're in pain, and they get fewer open-ended questions asked during. These are studies that my institute in Indiana did back in the 1980s, and they haven't been able to influence care. So the first thing, we have to continue to spotlight those things. The second thing is that we have to hold our leaders to at every level, hold their feet to the fire, from the highest level of showing those data to the health system directors and saying, this is what's happening. What can you do to make the care that you deliver colorblind? Because there are things that can be done. There are things that we at least attempted in the system that I was leading in, where 2/3 of our patients were African American. But all the way down to the level of the individual teacher on a ward service. For example, when I was rounding on the inpatient service at our county hospital, the first thing it says, well, this is a 52-year-old African-American male. So first of all, it's a man and not a male. Second of all, I don't care what race he is. If it's relevant, tell me that. But tell me when that's relevant. Well, he might have sickle cell disease. Tell me another one. And they can't think of another one. So, okay, if he has sickle cell disease, tell me a sickle cell disease. I know he's African-American. All right? So just the language that we use reinforces the discrimination. So I think at all levels, we have to put this on the wall and say this happens as often subconscious, but it's not to the person that is being discriminated against. But the system has to own the problem, realize, say we have this problem, and it's unacceptable. And I'm betting you, if you ask the health system leaders, and there's some here in the audience today, they would say that. They'd say, okay, what are we together going to do to make sure that we understand the degree to which it's an issue, and we start moving the needle rapidly away from that. I've worked my entire career in a minority community, and I'm absolutely dedicated to having that happen, and I think we can do it here. I honestly am encouraged in the conversations I've had that people want to move the needle on that. Now it's time for you to hold our feet to the fire, saying, what have you done in the last X number of months to make this happen? And so what you've told me is that the community is telling me that has to be one of our top of the fold front page foci. I can stand in comfortable silence.
Dr. Tierney. Dr.
Daniel, Mark.
Yeah, Dr. Tierney.
We have one here.
Oh, wait,
This is a follow-up question. We all know that the health disparities exist, and in the various communities, all our communities affected by health disparities, including the Anglo population, because it's also a poverty community. And you have to look at the various determinants of health when determining what those issues are and how best we can meet those needs of the people who are struggling with these very issues. But in order to do that, it's the bottom up that is going to be able to point us in the right direction, making sure that those various communities are included and engaged, and informing the academicians and the informationists, or all those experts in making sure that the data is appropriate and that the culturally competent and linguistically competent communities the various diverse communities are included and engaged in those conversations. What I have seen over the last few months has not been a representative conversation. I would like to know whether or not there is going to be a true effort to make sure that there is a representative grouping of diverse communities that make up what is Austin and what makes Austin great, and bringing those concerns to the table so that they're actually involved in the conversations and the development of those strategies, because they're not there. We haven't seen great amounts of the immigrant communities here. We haven't seen, and I don't know whether it's because their legal status continues to be an issue, and there are those that don't want to have that discussion about legal status and who's going to benefit from the dollars that are going to be spent, even though the overall community is most of all our goal. And also engaging those who are not able to communicate in the language in which we are conversing. And it's not only the Chinese or the Koreans. It may be the Burmese, or it may be the Middle Eastern, or it may be those that speak dialects, that we do have conclaves of those various communities here. We need to bring them to the table, and what is going to be done to do that?
Well, I can answer the question in a couple of ways. One is at the very highest level, we're absolutely committed to doing that. How we're going to do that, we're working out. I don't want to dictate how my director of community engagement and public health is going to do his or her job. This is hers or her job. I can tell you the things that we've done or committed to so far. And right now, I am the Department of Population Health. So, we have a little bit of a bandwidth problem, but we're working on that. But the two things we've committed to, one's the community strategy team is going to have 6 members on it that are selected by the community and they're going to be for 3-year terms, and they have 2 rotating off. So we know that one of the things that we were told during our summit was just because you have a representative from the community doesn't mean the community is represented. And I buy that. So that one group is going to rotate, and hopefully we'll be able to get many of, if not most or all of the different constituencies eventually in on that group. Second is that we plan to have regular fora, either monthly, every other month, quarterly, we don't know yet, where we go out in the community to different places in the community and just sit and listen. What do you have to tell us, and how can we help? Again, we're a small medical school that is energetic and wants to do something, so how can we help? So by doing that and then acting on it, having people in our section for community engagement and public health, we can actually take those ideas and formulate plans and work on getting funding for pilot projects and for things to show that what works and what doesn't, take things that works and then work with engaged stakeholders that we can then take those things to scale. The point is we can't do that without engaging the community. The whole notion of that is to do what you said. And that's the first thing that we're doing is fleshing out that before fleshing out anything else in my department, other than my chief of staff, who I really need real badly right now. Yeah. Mark, did you?
Yeah, just a quick question.
There's a mic here.
Quick question and comment, Bill. First, I'm very gratified to see that in the vision and mission statements for the department that you point out specifically that you want to pay attention to vulnerable populations and pay attention to health disparities. I think putting that directly into your mission statement is courageous and the right thing to do. And as somebody who's done that for a living, I'm very gratified to see that. Question is as the department begins to do research, and that research is being driven by the community, how do you see yourself setting up a department where you have researchers who want to research what the community brings them, as opposed to what they bring in their own heads and what they know the NIH will pay for in terms of research and promotion? How do you set up a research enterprise in that space? Because to me, that's new to you as well, new to everybody.
Actually, no, I've established centers for research in the past, so this is not new to me in doing this. This environment is, but the process of doing that isn't new. And there are a couple of questions embedded in there, and I can't answer the whole thing because it's going to be a long thing. But the first thing is that researchers need to be studying and innovating around good ideas. And a good researcher ought to be open to where the ideas come from. If the only place it's coming from out of their head or their literature, they're not going to be embedded in their local community. And they're not going to be solving the local problems. And we're going to be hiring researchers who that's their job. So by the very nature of how we hire people and how we set expectations, with a community-based participatory research, CBPR, we're hiring people specifically because that's what they want to do. So by their very nature, they're going to do that. Second of all, NIH and other funding agencies, specifically PCORI, want engagement of patients and stakeholders, and they're not getting it. So for the first 4 years that PCORI existed, for 3 of those years, I chaired their study section on comparative effectiveness research. And the criticism of almost every proposal is that the engagement of the patients and the stakeholders is all hand-waving. So the ideas came from the researchers, and they got rubber stamped by the engagers. And you can tell when the people are actively engaged. And so there are ways of getting that type of stuff funded. And there's also an evolution, and it's happening here and many other medical schools, and in fact, harder other medical schools, I think it's going to be faster here, is that all money's green. It doesn't have to be an NIH grant to get you promoted. At my prior institution, the rule was getting an NHR01 grant was neither necessary nor sufficient to get you promoted. What you have to show is you have a fundable line of investigation. And here, it's going to have fundable line of investigation that has to be impactful. So that's the other thing, is that the normal criteria for promotion and tenure are grants and papers, right? Grants and papers and recognitions. Our number one criteria is going to be impact. So if you do something, you publish it, and it ends up on the shelf, and nobody does it. And I've done studies that have ended up like that. Then you're not helping. And so we have to reinforce promotion based on not just other people's recognition of what you're doing by grants and papers and stuff like that, but also by the impact that it's had. And funding has to be a wide open mindset by the promotion and tenure committee that getting support for the things that you do and showing that they're impactful is credit towards advancement. And I'm not at all worried about that's going to be the case. So there are a lot of things behind there, but the engagement of the community has to be a real thing and not a hand-waving thing. But the way that we're establishing this, it's going to be kind of sine qua non. If people aren't engaged in the community, they're not going to be successful here. Yes.
Hi, Dr. Tierney. Thank you so much for talking to us today. My question is related to global health and how you touched on that being an important perspective for students to gain. And so my question is that the undergraduate medical curriculum is pretty packed. There's not the typical summer where a lot of students are able to go and travel and get those experiences. So how do you see global health experiences being worked into the curriculum, or how would you like to see that happen? Do you see, I guess, similar experiences available to residents? And also, are there certain healthcare systems or certain areas you'd like for students to go to?
Well, I can tell you what I'd like to see happen, and it's based on the experience of what we had happen. First, this is going to have to be the last question. There's going to be reception out afterwards. We can do more talking. But so I can tell you what I'd like to have happen, but I haven't even hired a director of that program yet, so it's going to be a while. There's still, I'd like to have senior student electives where they can do them overseas. Okay, so they are going to have the ability to do electives. There's also going to be a period in the third year, I believe, where they'll be able to do specially designed things for a period of several months. So I'm hoping that I'm intending that we'll have offerings within global health and those things. And yes, I intend for us to, as soon as we can establish a relationship with a developing country, to establish global health residency programs. We had those in Indiana in medicine, med-peds, pediatrics, anesthesia, OBGYN, radiology, and I'm missing one. But the point is that it takes funding, it takes energy to do that, and it takes an infrastructure where they can safely go back and forth, et cetera. We intend to do that. Okay. I want to thank everyone for coming, especially the Board of Central Health and the representatives from Seton and both from the medical school and from the community and from the various organizations that I've touched since being here and many that I've yet to touch. Thanks for coming, and please tell us how we can help. Okay, thank you.